Hi everybody and welcome to this month's session, which is surrounding managing a patient's airway. So what we're going to be looking at with this session is we're going to look mainly at why the airway is so important to be effectively maintained. We're going to dive a little bit just into the anatomy of it. We're going to look at why we follow a stepwise approach to airway management, why we're not just going straight to intubation or needle correct and anything like that. And then we're going to follow that sort of stepwise approach, thinking about inspecting the airway, what can we hear, what can we smell, what can we see. We'll look at choking patients, using a suction kit. We're going to look at putting the patient in the recovery position, which is mainly for ensuring that the airway is well protected on an unconscious breathing patient. We're going to have a little bit of practice with head tilt, chin lifts and jaw thrusts, and then finally we're going to look at inserting an OP airway as well. So, little bit of airway anatomy for you guys here as well. So what you mainly to take note of things like how big the tongue actually is, because I mean for a lot of us we really can't just see how big our tongues are. So this is quite important when we think about airway management and we start to speak about the most common thing that blocks an airway. A lot of people also get quite surprised as to how big the cavity is behind our noses as well. And as we can see here as well, this is somebody who is breathing happily through their nose, bypassing the epiglottis here. This is the trachea, so if we were to follow this down, it would go into the person's lungs. And here, this is the esophagus, which will go into the stomach. So when we eat something, we swallow it, and what should happen is this should close off, and food will bypass down this area here, so it doesn't go into your stomach and not into your lungs. Again, particularly important to think about this with regards to choking individuals, which we'll be looking at in a bit more detail later on. So, why is airway so important here? Why do we prioritise it over breathing and circulation or broken ankle, whatever? We think about our systematic approach. Once we've looked after ourselves, we've assessed whether or not the patient is alert or if they're only responding to voice or unresponsive. Obviously we need to manage catastrophic bleed as well. Airway is pretty high up on our list of priorities here. So we're trying to think why. Why is it so important that we manage an airway before we start worrying about whether or not they're actually breathing? So a little bit of standard grade biology here for you guys. Don't worry, I will not go too in depth for this. But what we have here is the main reason why an airway is so important. So we're thinking about what is one of the most singularly important cellular activity that happens in the body, which is respiration. So what we're looking at here is what happens with normal cellular respiration. So which is where we take the food that we use, so any food that we eat, and we derive energy out of that food. And that energy is in the form of something called ATP, which is used for everything in the body. We cannot function without this equation that's sitting behind me. And the biggest part of that equation is oxygen. So with this is demonstrating what we call aerobic respiration, which uses oxygen. Without oxygen, we go into something called anaerobic respiration, and the main byproduct of that is lactic acid, which, as we know, acidic conditions are not overly great for the body, and cells will start to die. So cells will try to still create this energy, the body will still try to survive in the absence of oxygen, but it will create quite a toxic byproduct with it. So going back to our respiratory anatomy here as well, just to demonstrate again. So if we think about, if we have a blockage here, which is usually normally tends to be when it happens, Everything below that, so this, the main centre in our lungs, where obviously is where the gaseous exchange takes place, so we get oxygen in, we get carbon dioxide out, cannot happen because this area here is blocked. So that's why we are so passionate about making sure that this airway is kept clear, because if it's not, then we can't get oxygen in, we cannot get carbon dioxide out. The end result of that is the body becomes very, very acidic very quickly. You become cyanosed, cells start to die off. So yeah, it becomes our top priority then to maintain. In some ways you could argue that the human body is a little bit stupidly designed, I guess, because why would we have really one area for such an important part of our body? You think we would have a hole somewhere around about here, it's close to the lungs. Hey ho, that is how the Lord hath created us. So we just have to make sure that we maintain it as best we can in a medical-based emergency. So, what can block an airway? Pretty much anything. Pretty much, if you can get it in your mouth, it's going to block. So, but the main things that can block an airway is number one thing here is the tongue. As we looked at earlier on in that diagram, your tongue is really quite a large muscle, and it's when you're conscious, when you're able to speak, it doesn't present as much a problem. However, what tends to happen with most people is when they're unconscious, that muscle becomes floppy, and of course when people go unconscious they go on their backs, it flops backwards, it blocks the airways. This is usually one main concern with regards to airway, is a person's tongue. Vomit is another common thing that we see. So again, somebody falls unconscious, everything around about the abdominal region relaxes, and that contents in the stomach comes up, and when you open the airway you'll tend to find that actually you've got quite a lot of vomit in there as well. Sweeties is quite a common one, particularly with kids. They're just the right size for blocking the back of your throat. Another consideration for airway management is swelling as well. So this person's here is obviously suffering a severe allergic reaction, is going to anaphylaxis. So our bodies can sometimes be, the response that they have to certain things can be detrimental to ourselves as well. So someone who's suffering from anaphylaxis and they've got quite a lot of swelling around about the throat, our main consideration is, or our main concern is with regards to airway management, because the swelling can make things very, very difficult for us at times. So why do we follow a stepwise approach to airway management? The reason is that because often the most simplest basic method can be the most effective. We look at airway management as a ladder. So we start at the bottom and we work our way up. As we work our way up, we may gain a greater reward, but with that comes an increased risk. So, for example, if you are going to use an OP, which is as high as you guys will go on the ladder, there's not that much risk with using an OP. You can have to be quite careful with inserting it, make sure you don't hinder the soft palate at the back. But there's a reasonably good reward associated with it, so because you're physically pulling that tongue forward and you're maintaining that airway. However, you can still, as we'll see later on, patient can still be sick and there's still a risk of aspiration, that vomit actually getting into the lungs. Now, we can use eye gels, advanced practitioners can intubate as well, so there is an increased benefit with more advanced airway management. However, you're intubating someone, you can intubate into the wrong place and go into the stomach, and that's a huge risk, huge risk. You will tend to find that even us as paramedics, we'll be more than happy with just using an OP. If it's effective and it works, why go up the ladder if there's no reason to? You always have to justify why you go up the ladder. There is certain circumstances that we can justify going straight to intubation or even straight to needle crowd. Is needle crowd the most effective airway management technique? No, but it's the last ditch option. But most of the time you'll find if a patient isn't being repeatedly sick, or if it's not a drowning patient, anything like that, we will stick to an OP because it's effective and it's easy and it's quick to insert as well. So don't think that just because you guys carry OP airways and you're not working with eye gels or anything like that, that it's not an effective way of managing an airway, because it is, and you'll find a lot of the time that that's as far as what we'll go up the ladder, because the benefits far outweigh the risks and the time that it takes for inserting an intermediate or advanced airway. So the first thing that we do, always the bottom level of your ladder, the most important thing, we're going to inspect the airway. We're going to have a look at it, because that first few seconds of looking at the airway is going to tell us a lot. So this is all the kind of things that you might see here. So we're thinking about what can we see, what can we hear, what can we smell. So vomit. Vomit's one of the most common things that we are probably going to see as well. And I'm sure you can all imagine what that smells like. So vomit is a nasty substance because it's very acidic as well. It is really bad when people aspirate. So when I say about aspiration, I mean it's coming up from the stomach and going back down into the lungs again, because that will actually destroy the little structures within the lungs. That damage causes swelling, can cause things like secondary drowning and things as well. So we're really, really conscious of vomit and making sure that that's not going to go anywhere but up and down the esophagus, not into the lungs. I don't know how well you can see that, but this is an indication of someone who has got cyanosis or hypoxia. So you walk into a room and check for danger, you've done a response, you've considered your catastrophic bleed. When you start speaking to that individual, and the first thing you see is this blue tinge around someone's lips, you're already starting to think, okay, are they getting enough oxygen? And if they're not, why? And you'll see that within seconds of speaking to that individual as well. So cyanosis, hypoxia, is something that we might see as well, even well before we put the SpO2 probe on their finger. Again, we spoke about swelling as well. So again, if somebody's got a swollen airway, then we're thinking, are they getting enough oxygen in? Trauma is another one as well. So if you come and you find there's quite a lot of blood around about the mouth, maybe someone's fallen forward, start thinking about things like broken teeth. If they've got dentures, are they still in place? Because as we find, particularly with using a BVM, we will try and keep the dentures in place, because someone who normally wears dentures and they're no longer in place, the mouth tends to collapse. You don't get as good an airway, as a good seal. This one here, smoke inhalation. Again, we'll speak more about smoke inhalation and carbon monoxide poisoning on our breathing month, but this is something, again, which you will see within a few seconds of walking into that room. If they've got soot around about their nose, again, you're starting to think about, okay, there's potential for carbon monoxide poisoning here, what's going on there? And this one, you will tend to find, so this person's got, there's just a bit of a white tongue, so it could be a bit of infection, could be a bit of dehydration going on there as well. This will all come with regards to patient history, if they've been vomiting over the past few days, not quite looking after themselves. You can actually learn a lot from somebody's mouth just within that first initial assessment. Again, this is one of the reasons it's so high on your systematic approach as well, because we tend to build such a good picture simply just by speaking to someone. So that first few seconds, as I say, just looking at someone's airway is actually very, very important. So Blocked airways, the choking patient. Again, thinking, well, what can we see, what can we hear, what can we smell? What you're going to see is somebody, hopefully, if you're in time, panicking. Usually you tend to get the typical person holding their throat panicking. You might start to see already a bit of cyanosis. They're going to turn blue very quickly. What you're going to hear, nothing. That's no sound is very worrying sometimes. So if you walk in, you find someone that is grabbing at the throat and they're not able to speak to you, and all you get is you're thinking choking patient. This is a very serious medical emergency which needs corrected ASAP. A lot of times, by the time we get there, if it's someone who is properly choking, they're going to be unconscious as well. This is the point we're starting to think about, okay, we're going into CPR here. So, how are we going to clear the airway of a choking individual? So, first thing we do, we're going to try and encourage them to cough as well. So, as we get on scene, you've been quite quick, so you get in there, you notice that they're holding the throat, you can't hear any sounds, any breathing sounds, they're not able to speak to you. Ask if they can cough, try and encourage them to cough. After this, what we're going to do, I'm going to take my mannequin and show you properly in a moment, but we're going to give them 5 back slaps or 5 back blows, making sure that we reassess every time we give that blow. And after that, if your 5 back slaps don't work, we're then going to move on to abdominal thrusts as well. So I'm just going to demonstrate that for you now. Okay, so here we have a choking patient. Again, presenting just as we said before, grabbing their throat, can't hear anything. I've encouraged them to cough, no success. So we're going to move on to 5 back slaps. So I'm going to support them from the front, because if I possibly if I hit them from behind, even a wee person like me, they're going to go flying. So make sure you support them with one hand at the front, and then from the back, you can't see it overly well on the mannequin, but what we're doing is we're aiming right between the shoulder blades. I'm going to use the bottom bit of my hand here at my palm, and I'm going to give a right good sharp blow to the right between the shoulder blades, trying to almost imagine you can see the obstruction and you're trying to force it out. So we're going to go 5 of them, check in every single time. So 1, 2, 3, 4 and 5. So I can see that hasn't done anything. So what we now need to do is move on to abdominal thrusts. So you're going to go just below the diaphragm here. So you think that your diaphragm comes across the chest here. We'll look more at this when we speak about breathing next time. So I can feel each end of the rib cage down there, and my hand's just going to go here. I'm going to make a fist with one hand, put my other hand over the top, and again I'm going to pull in towards my belly button. So kind of inwards and upwards. Again, you're going to do this 5 times. I'm going to check each time to see if I've been successful. So 1, 2, 3, 4, 5. And again, that's not been successful. So what do we need to do now? I'm going to return back to my 5 back slaps. I'm going to keep going and keep going. If this doesn't work, then my next move is to prepare for CPR, because that person is going to they're going to go unconscious, and they're going to go into cardiac arrest as well. If this happens, start CPR. What might happen is when you go unconscious, obviously everything's going to relax, and you might find that as you're doing CPR, whatever was obstructing the airway might come back up again. So this again is why it's important to keep reassessing that airway, and if you can get it out, great. Get them on the sides, make sure that the airway is cleared. So next thing we're going to look at, guys, is use of your suction kit. Have a little practice of pulling this kit in and out of the holder in the ambulance, because it can be a little bit tricky, and if you're in a situation where you need to recover it quite quickly, you're going to want to practice actually taking it out before you're in that situation as well. So let's have a little look at how we use this kit, how we measure it up. For the majority of you, your suction kit will be located up at the top right of your vehicle, and to remove it just lift this and pull it out, so it'll probably stick on your oxygen point there, and then just lift it out. To get it back in, it's just the reverse. Again, making sure that you're tweaking it behind there, seating it in, lifting this tab here, and it should just click like so. That's it in nice and secure. Okay guys, so this is your suction kit here. So we're going to have a look at the components on it first. So what you've got here to start off with is your dial for turning it on and off, like so. So for adults, you're going straight up to the top and back down again. You guys should be testing these on a regular basis, so that means removing them from the ambulance, turning them up to full spec and just testing it. You should get right up to the top. We are perfect, and just make sure that the battery's in good working order. Moving along, this is your suction bag here, which you remove just by pulling it out like so. This is the bit that gets dumped along with your suction tubing and yanker. To replace it, you just pop it back in like so. Obviously not the same bag, a new one. If you find that the suction unit gets a little bit dirty as well, you can actually remove this whole section here, like so, and give it a right good wipe down, which you guys should be doing fairly regularly, or certainly after each job. That's it, instead like so, nice and easy. At the side here, you've got your main suction tubing and your yanker. Some units have a soft catheter with them, not all of them. Soft catheter tends to be used for paediatric based patients or for the use on intubation tubes and things. So if you guys don't carry it, I wouldn't be too overly worried, but do make sure that you've got your suction tubing and your main end of your suction, which is, I say, is the anchor. So I'm not wasting the kit. I have got two here that's been pre-prepped. So main thing to take note is with your suction tubing. Take note that both ends of the suction tubing looks exactly the same, so it doesn't really matter which end you insert, because they're both exactly the same. However, with your yanker, they're different at each end. So this end connects to the tubing, and that end, which you'll not be able to see at the moment because you would need to zoom in, has got little holes on the end of it as well. It just makes sure that if this blocks, then it'll still be suctioning around about the outside. So make sure that you're connecting it up correctly, which is that way. So you see the angle there, so that's correct. Don't block the holes, that is wrong. This is right. So moving on to how we actually suction a patient. So remember your stepwise approach to airway management. So we are inspecting the airway first. So checking in. We're noticing that I'm not tilting the head back, so we're not moving on the head tilt chin lift yet. I'm just checking in that airway. I've inspected it and I can see there's quite a lot of vomit present. So I'm either going to use postural drainage, which is going to be the most quickest and probably effective method in this case, or I require the person to be lying on their back or in a cardiac arrest situation, for example. So I'm going to use my suction kit. How I'm going to do that? Firstly, measure. So got my end of my suction tube in here. I'm going to measure from the angle of the jaw here to the middle of the incisors. So what I'm going to do is I'm going to pinch. Now the reason for that is so that I don't go any farther than that point. So make sure I've got that pinched. It's actually more easy to make sure you've got all this connected up first. But once I've got that pinched, connected, I'm actually going to insert this first. So a lot of people ask, do you turn it on first and then suction on the way down, or do you insert it and then suction? So I'm going to suggest that you insert it first, because if you turn it on first, you're going to start suctioning the cheek and the tongue as you go down. So we're going to insert. I'm going to set it first. I'm also not going to take my eye off of the end of it either, because I don't want to insert it too far. We'll keep an eye on that. I'm going to turn it on, and then I'm going to suction outwards in a figure of 8 motion. Suction out, once I'm all the way out. Then I'm going to turn it off, and of course, because we've done something with an airway, every time we do something with an airway, we reassess to make sure that we've been successful. So reassess, that airway is now clear. That's how we suction. So just a little note here, guys, as well. Again, we spoke about sometimes the most simplest method is the most effective. And while we can clear an airway that's full of vomit very effectively and very quickly with the use of suction kit, keep in mind that we can use postural drainage as well, and sometimes, to be honest, you're going to be just as quick. If you arrive on scene and you find that someone is lying on their back and they're gargling and they're at risk of aspirating vomit, get them on the side. Don't run to the ambulance and get suction kit, get them on the side. As we say, the most simple basic method for airway management is often the best. Yes, we've got the Gucci kit, we've got the suction kit handy, and if you've got it handy, great. But more importantly, if you can get them on the side and you don't have to have them on the back, so i.e. in a cardiac arrest situation, get them on the side, get that airway protected ASAP. So, speaking about getting people on the side, let's have a little look at how you put someone into the recovery position. Okay, so we have followed our systematic approach, and I've checked for danger, I've checked for response. I've got an unconscious patient here, no sign of catastrophic bleed. I've assessed for the airway, I've assessed breathing circulation as well. So what I have here is an unconscious but breathing patient. I'm not needing to go into a cardiac arrest scenario, but I do need to still protect his airway because it's currently at risk of him lying on his back. So we're going to put this individual into the recovery position. Before I do this, it's good practice just to give a quick check of pockets. So just making sure that before I roll him onto his side, there's going to be nothing that's going to be pushing onto his legs. Things like glasses that might break, phones are another one as well. They'd be quite uncomfortable, can sometimes cause pressure sores, particularly on elderly individuals. So putting someone in the recovery position, the hand that's closest to me here is going to go into the how position. So just like so. This hand that's farthest away from me, I'm just going to take a hold of that. You can interlace the fingers, which makes life a bit easier. So the reason I'm going to keep a good hold of that is because if I let go, it's going to flop right back down again. So grabbing all his hands, interlace the fingers, back of his hand is going to go against the cheek here. And then this leg and this knee, it's farthest away from me. I'm just going to lift up. And then all you got to do after that is just roll the individual towards you. Once I've done that, I'm just going to straighten out this leg so it's nice and secure. Open up the airway. And then again, making sure that I'm reassessing the individual at all times. If he vomits in this position, I've got nice postural drainage, so the airway should not be at risk. Okay, so moving our way up the ladder here, we've inspected our airway, we've cleared it if required. Now we're going to look at properly opening it. So first of all, using a head tilt chin lift. So keeping in mind, when someone is lying on the back like this, as we can see, the tongue is going to flop back and it's going to obstruct our airway here. So it's up to us to use a head tilt chin lift or a jaw thrust if there's a C-spinal query, in order to lift the tongue off of the back of the throat and open it. The next two techniques that we're about to teach you is the most important thing that we can teach people really with regards to managing the unconscious individual. Simply doing this, simply opening the airway, could be enough just to save that person's life. The number of times where we will come on scene and people will be absolutely panicking because the person is snoring away on the back and they'll be becoming really sinus, and simply tilting that head back, simply getting that airway clear, has been enough to allow that person a significant recovery. So let's have a look at how we perform a head tilt chin lift. So before I perform a head tilt chin lift, obviously I'm going to follow a stepwise approach. So again, making sure I'm inspecting that airway first, making sure that there's nothing that's going to then obstruct the airway when I open it. So if there is a lot of vomit in there, I'm going to fix that before I open the airway with a head tilt chin lift, because I don't want that vomit that's in the mouth to go and be aspirated into the lungs. So stepwise approach, checking the airway, it is clear, because we've got a nice clear airway, but it's still blocked by the tongue. In order to lift the tongue off, I'm going to do a head tilt chin lift. So this hand goes on the person's forehead, and I'm just going to tilt that back like so, and make sure that that chin is kind of nicely supported, and lift it open. As I'm going to mention in a moment, when I signal let go of that airway, it's going to block again. So you need to make sure that if you're performing a head tilt chin lift, you maintain it at all times, or otherwise we'll speak about OPs in a moment. Next manoeuvre that we look at is jaw thrust. So if you've arrived on scene and you've done your initial scene assessment and you're thinking that your mechanism, nature of illness is possibly linked to it's a fall and there might be a spinal injury there, this is what you're going to look at, which is a jaw thrust. So I'm going to put a link in the comments to a video which demonstrates the difference between a head tilt chin lift and a jaw thrust. It's really, really good for showing how much spine or this bit of your spine moves when you do a head tilt chin lift. So it's not ideal if you have a concern that someone has a break here. The last thing you want to be doing is causing any excessive movement to the head. So we will be doing a jaw thrust in order to maintain that airway. So let's have a look at how we perform a jaw thrust. So for this individual, when I have been doing my 5-step scene assessment, I have recognised that there may be a mechanism which will lead to a C-spinal injury on this individual. So the last thing I want to do is to be moving the neck at all. However, as he is in neutral alignment at this moment in time, I can be hear snoring that's going on, and I'm concerned for the airway. So again, following the stepwise approach to my airway management, I would first be inspecting to make sure that there's no vomit or anything. I'm not going to use a head tilt chin lift because, as you can see, that's going to cause quite a lot of movement around about the C-spine. So in order to maintain that airway, what I'm going to do is a jaw thrust. So the main anatomical points I'm looking for is the flat aspect there in the mandible. So what I'm going to do is I'm just going to take my fingers, and what I'm aiming to do is to pull that tongue. So the tongue is attached to this area of the jaw here, and what I'm going to do is I'm just going to pull it like this. So I'm going to pull that tongue up along with the jaw. So as you can see there, it's kind of, hopefully you can see on my fingers. So making sure that I'm not, or I'm certainly causing as little movement to the neck as possible. I'm not doing this because that defeats the purpose. I'm making sure that all I'm moving is the jaw. So jaw gets pulled up, my thumbs is going to go onto the tip of the chin here, just open the airway like that. You'll find that when you guys are practicing this, it is quite difficult to do on a stiff mannequin. It's a bit easier on a real person, but still quite difficult to maintain, so might have to move on to an airway adjunct such as an OP. So again, with the flat aspect there, fingers go into the back of the mandible, pulling it forward and opening the jaw like so. And as I say, this is currently an open airway because I've got the tongue off the back of the throat. This is closed, so keep that in mind. You're going to have to keep that position in order to maintain the airway. Lastly, at the top of your ladder for you guys is inserting an OP airway. So head tilt chin lift, jaw thrust are both really easy ways of maintaining an airway. They're quick, they're effective. However, the second you let go, that airway is lost. Again, a lot of the times when I see people doing a cardiac arrest scenario, and they'll do a nice head tilt chin lift, and then they'll let go when they're checking for breathing, and I've got to remind you, look, that's now a closed airway. So if you're checking for breathing, maintain that head tilt chin lift. That is all fine and well, but if you've got many hands available, which we don't have the luxury of, usually there's going to be 2 of you at a cardiac arrest. So what we do is we use airway adjuncts to maintain that airway for us. And for you guys, that adjunct is an oropharyngeal airway or OP airway. So how it works is just as you can see up here. When it's properly inserted, its duty is just to lift the tongue off the back of the throat. There's a hole through it to allow for oxygen to pass through. As you can see, as I mentioned before, take into consideration the fact that, so here's your esophagus, here's your trachea, this goes to your stomach, this goes to your lungs. Stomach contents can still come up, and you may still see it come up through your OP. It can block, so just keep that in mind. Keep in mind that you may need to suction, you may also need to take the OP out and reinsert a fresh one as well. So just keep that in mind. This is not a fail-safe for someone who's repeatedly vomiting for you guys, and it's a reason that we would be moving up our ladder for an iGel. So let's have a quick look at how you insert an OP airway. Okay, so again, following my stepwise approach to airway management, so making sure that I'm checking the airway first. We could use head tilt chin lift or a jaw thrust on this individual. However, because this is something that we need to maintain at all times, it is not going to be my best option. So I'm justifying using my airway adjunct, which is an OP. So I'm going to have a quick check just to make sure that they've not re-vomited again before I insert this OP. To measure it, I'm going to go for the middle of the incisors to the angle of the jaw, which is there. So this looks about right. And then all we have to do is we invert it, so we're going upside down, invert, insert, and then halfway I'm going to rotate, so I'll sweep the tongue out of the way, and place. As easy as that. We can insert them anatomically as well, so just pull it out like that. If you have the use of tongue depressor, you can put them in this way, but it's just a little bit more difficult, so that is why we put them in like this, upside down. So invert, insert, rotate, and place. And again, because I've done something to the airway, I'm going to reassess to make sure that that airway adjunct has been a success. So quick reminder again, guys, so for measuring your OP, you're looking for the midpoint of the incisors to the angle of the jaw. Guys, the human body is not a perfect thing. If you, and I get a lot of people asking, like, oh, like if I insert an OP and it's not quite right, what do I do? If it's too big, go down and insert the smaller one. If it's too small, insert a bigger one. There is no human jaw that is textbook, trust me. And it happens where you will put an OP in, you think you've measured it up absolutely perfectly, and suddenly when you try to ventilate them, you're finding actually it's not that effective and your airway's not being effectively managed. It's actually rattling around a bit, it's a little bit small, no problem. Insert a bigger one, it does not take long to do. What is the important thing is to reassess. So every time you do something to the airway, reassess it, because there is no point in you inserting an OP and just accepting that, right, that's gospel, it works. Doesn't work like that. So make sure that, say, put your OP in now. Does that feel better? Yes, it does, or not quite sure about that. If they vomited, this is something, because this situations are interchangeable. So constantly reassess and fix, adjust if you require. So we're just going to finish up a little section now that's to do with difficult airways. So have a little think about what kind of patients we might come to that we would think is going to present with quite a difficult airway to manage. I added this in at the end because every time we practice with a mannequin, it's a nice adult dummy that is of easy size for us to manage, whereas 90% of the time that's not going to be the case for us. So something for you guys to think about. Again, this will come on your initial impression of the patient as you walk into the room. When we are actually looking at somebody, we're thinking, right, how difficult is this person going to be to manage here? So firstly, bariatric individuals. Now, bariatric individuals make for very difficult airways to manage. So as we can see here, I've got quite a lot of visceral and subcutaneous fat. What that does is, so when they're lying on their back, obviously belly kind of pushes the lungs up. That reduces the lung capacity, lung volume, and you're also going to get, if you've got like quite a short neck or quite a lot of fat around it, it makes life very, very difficult when you're trying to manage an airway. So for someone like this, just if you walk in and you see someone who is carrying a little bit extra weight, know immediately, okay, I'm going to have a little bit of difficulty ventilating here. I'm going to have, well, more difficulty is what I would normal sized person for inserting an airway and managing that airway. So we speak about ear to sternal notch, this sort of line here. And I mean, you can see this looks quite extreme. This is more important for someone who's trying to intubate, so insert a tube, because trust me, you put your laryngoscope in that, you're not going to see anything. It's going to be really, really difficult to see the anatomy there. So what we'll do in surgical units or even out in the field is we'll seek to prop the head and the shoulders up so we can get a better look, and so we can actually have a chance of seeing the vocal cords for putting a tube in. For you guys, obviously you're not so concerned about seeing the anatomy or landmarks. However, it may make life more easy for you to consider just propping up the shoulders with a blanket, or propping up the back of the head if you're struggling to get good ventilations with your BVM. Just as I say, take it into consideration. You come on scene, you've got a bariatric individual that's present, you're struggling to get good ventilation with use of your BVM, even if you're inserted in OP. Just think about how your trachea is lying, and again, reassess if you've adjusted something on the airway. Is this working? Another thing that can fill the abdominal cavity, babies. Obstetric patients, maternal, particularly third trimester. MATI patients can be quite difficult with regards to airway management. Again, when you've got them lying on their backs. So for two reasons really. One is obviously because baby is pushing on everything. The other is hormones. What a lot of maternal-based hormones do is they relax the sphincters that's at the top of the stomach, and that means that they're more likely to regurgitate. So you'll be quite likely to see vomit and that coming up with someone who's particularly in the third trimester with baby. Obviously we'll speak more about obstetric-based emergency when we get into cardiac arrest as well. You don't want to be lying someone who has got a baby around the third trimester on their back. So if you arrive on scene and the first thing you see is a third trimester mum lying directly on her back, quite a gravid uterus. First thing we're going to be thinking about is getting her on her side. Again, because we're concerned for stomach contents coming up, we're also concerned for baby pushing on veins and arteries when she's lying on her back. And finally, paediatric airways. So this is something that you guys should not be having to deal with yourselves. You will not be carrying paediatric kit at any time, but again, it's just nice for you to have a little underlying knowledge as to why we are more concerned with regards to peds airway as what we are in adults sometimes. So kids have tongues that are a lot bigger, and their mouth cavity is what adults do. We also think about things like the epiglottis as well. It's floppier. The reason why I mentioned that as well is we think about epiglottitis, stuff like that. So a lot of upper respiratory infections maybe wouldn't affect an adult as much, is going to affect the child quite severely. So if you hear a child that has like a barking cough, or you have something called stridor, these are all resulting from infections that, as I say, for an adult we wouldn't be overly considered about, but for a child, because their airways are a lot narrower, we're going to be more concerned for things like swelling because of infection, because that swelling is going to have far more of an impact more quickly. Lastly, the other thing that we look at is the trachea, so that tube that goes down into the lungs. That tube has cartilage in it, and when you are a child, kind of infant baby, that cartilage is not as rigid. So if you see us ventilating a child in comparison to an adult, we'll be less likely to tilt the head back when we're ventilating, because what happens is that the trachea is likely to collapse because we don't have the rigidity that we would in an adult. So just to make you guys aware, if you see us ventilating, then you're going to notice that we are not tilting the head as far back. We're going to keep them more in a neutral alignment. As well as that, obviously kids have got quite heavy round heads, tend to move around. So you will tend to see us putting a blanket of that behind the shoulders, just to make life a bit easier for us with managing an airway. So that's the end of this month's session. It's up to you guys now to take your kit out and have a play with your mannequins, practice using suction, practice inserting OPs, and just generally managing your airways. Hope you enjoyed this, and we'll see you in the next video. Bye!